All right, so let's start getting to the heavier stuff now. Obstructive diseases, and then we'll talk about restrictive diseases. Okay? So obstructive diseases, let's first talk about sleep apnea, right? You've all heard about sleep apnea, right? Sleep apnea, all right, is when there's no breathing while sleeping for greater than 10 seconds. Apnea means without breathing. It's usually due to the fatty tissues in the back of the throat. This is very strongly associated with obesity, but not all obese patients have this. And one of the things that they're going to use to treat this is to lose weight. Even if you lose 50 pounds, there's no guarantee that this is going to be fixed. Okay? 5% of people have this. We see it a lot more in males than females. And like I said, obesity is a risk factor of this. Symptoms of this is snoring. That's usually the #1 thing on here. All right? My father has sleep apnea. And I don't know what's worse. His snoring, which had a Richter scale of about 7 or 8 that would just shake the whole house. And my poor mom, wake up, you know, that kind of thing. Or not breathing. I would hope that not breathing is more important. But that's what it is, it's snoring, because the tissues in the back of the throat are flabbing. That's what's happening. The snoring actually is worse if you're lying on your back. Because as you're breathing, the fatty tissues in the back of your throat are laying down because of gravity. If the person's on the side, it's not so bad. If they're lying on their stomach, it's not so bad. It's when they're laying on their back, which is a lot worse. They think they had a good night's sleep, but they really didn't. They wake up, they say, yeah, I feel good, and then throughout the day, they're taking naps. They feel as though they're getting very tired, all right? They get daytime fatigue. They get irritable, mood swings. Ah, leave me alone. I've seen that. Believe me, okay? They take naps throughout the day. Many deaths usually occur at car accidents because they fall asleep at the wheel, okay? So, like I said, the treatment for this is, one, to lose weight. Hopefully that's just a non-medical way of doing this. But there's also something called continuous positive airway pressure. We call it a CPAP machine. And what that does, it goes on the nose while sleeping, and it lets a positive air go through the nostrils straight down. So it kind of opens up the airway, and it's continuous. And it shouldn't be so bad. They have to adjust it so that you can fall asleep. I think it's more of a problem falling asleep, not because air is going through there, but because you've got this little mask thing that goes on your nose. But they get used to that. They get used to that. All right? So it's this positive pressure of airway that's going down to keep the fatty tissue over there open so that we can have airways open. Questions about sleep apnea? Okay. Asthma. All right. Asthma is a hypersensitivity disorder. And it's usually triggered by either an antigen, could be smoke, could be dog hair, could be hay, could be pollen, or it could be due to stress, an emotional upset. All right? You just found out, God forbid, your mother just died, and that starts off, that triggers this whole asthma attack. Okay? There could be also secondhand smoke that can cause this. Even aspirin can cause this. So a lot of asthmatics, we don't encourage them to be taking aspirin because that could start off, that could trigger an asthma attack. Okay? And there's a lot of other reasons that would cause triggering of this. So what happens here is 3 things. And all 3 is going to lead to narrowing of the lumen of the bronchioles. So what's happening here, if you normally have a bronchiole that's like this, so there's our lumen, so all that air can get through there. In someone who's got asthma, there's going to be a bronchial spasm. So what happens is this starts to spasm. Spasm. Which means that this gets smaller. It bronchoconstricts, but a spasm. So that's going to contribute to the lumen getting smaller. And because of this inflammation, because it's a hypersensitivity reaction, this is actually going to get inflamed. This area here will get inflamed, which means now it's going to get even thinner. Or, I'm sorry, the lumen is going to get smaller because it inflames, gets thicker over here. And because you've got an inflammatory process going on, it's going to produce, you know, the 5 cardinal signs of inflammation. It's going to put extra water, right, swelling, which is that part there. It's going to put extra water into this area here, an inflammatory cell, which is also going to contribute for the narrowing of that lumen, okay? So all of that's going to contribute. So now these people with asthma are trying to get air, and the air that I'm saying is to get the air out going through that narrow passageway. It's going to be the, right, that wheezing going through, air going through a very narrow passageway. Okay? Questions on that? Asthma? Okay. So you get severe dyspnea for that, short of breath. Audible wheezing, if it's so severe, you actually hear it through the mouth. Okay. Mucus production, you'll get a cough, and it's just difficulty in expiring, getting that air out of that narrow passageway. We also have a condition called status asthmaticus. This is very bad. This is where they have the asthma attack, and you treat it, and then 20 minutes later they have another asthma attack. You treat it, and 10 minutes later they get another asthma attack. You treat it, 15 minutes later another asthma attack. It just keeps on coming and coming. These are very difficult to manage. We also have another one that really has nothing to do with this. It's called status epilepticus. And that's similar in a sense that they have a seizure, and then 15 minutes later after treatment they have another seizure, and another one, and another one, and another one. Those are very difficult to manage. These are the people that usually will die from this. Okay? Either status asthmaticus, or in that case, status epilepticus. Okay? So, for asthma, it's usually a good prognosis, but do keep in mind, it is fatal. There's a lot of people dying from it. But if you have medication, it has a good prognosis. Okay? Questions about asthma? It's a pretty big one. Okay. And that's what I'm saying. I kind of gave you the highlights, but there's other issues that you need to read. Just read that paragraph or two, whatever it is, a few paragraphs on asthma, and just fill in what I didn't cover. But that's enough to take you to the next level. Okay. Big one now. Emphysema. You've all heard of emphysema. You just don't know what it is except it being a lung disease. All right. It's irreversible damage to the alveoli. Smoking is the #1 cause for emphysema. Okay? So this is, excuse me, this is a decrease in elasticity. So like I said, think of this old flabby balloon that you've blown up 4 billion times. And it's easy to get the air in, but it's difficult to get the air out. There's a lot of air trapped in there. So let's do that balloon again. We normally put air into a balloon. This balloon gets big. You let go of the nozzle, all the air comes out. That's the way you and I do it. But in a person who's got emphysema, an old baggy balloon, they blow up the air into, or they blow air into the balloon. The balloon is going to get much bigger than what it would normally be. Because it's overly stretched. Easy to get the air in. But when you let go of the nozzle, all that air, and then there's air left in there. So you, and watch this, you have to use your accessory muscles to squeeze out the rest of the air. You have to use your arm muscles to get everything else out. And that's what these patients have to do. They have problems getting the air out. So you see these patients, all right? I'm not picking on them, but go to Walmart, all right? I see the people in Walmart. They usually have the oxygen tanks in their carriage. They usually have the nasal cannula in their noses, and they're walking around. Now look at the way, I mean, don't stare at them, right? But look at them, you know, subtly, and look at how they do it. They're actually leaning forward, all right? They're trying to do things to get the air out. So they lean forward, trying to make that thoracic cavity smaller to try and push that air out, okay? They usually have these pursed lips trying to get the air out. And we'll talk about that. But what that does is They usually breathe like that, like. What they're doing with the pursed lips is that they're actually creating a positive pressure of air so that any air that comes out, the lungs don't, or let's say the bronchioles, the airways don't collapse. It's like kind of using a straw and blow out. It's going to keep the pressure so that all the air doesn't, if it comes out fast, if it does, the walls don't collapse on themselves. So there's always like a small amount of pressure that's happening there so that nothing collapses. And they don't realize that they're doing the pursed lips. That pursed lips is kind of an adaptive thing that they don't realize that they're doing. But look at them. Again, don't stare, but I mean, you'll see, you know what I'm talking about, right? When you go and see these. Yeah. But that's what they're hunched over. They're using their abdominal muscles trying to squeeze out that air. They're using their intercostal muscles, the muscles in between their ribs, all right, to try and squeeze out that air. They're using everything they can to try and get that air out. It's difficult for them to get the air out, okay? So think of, when you think of emphysema, think of that old flabby balloons that have been blown up 4 billion times. Easy to get air in, but hard to get air out, okay? So that's what happens, the old flabby balloon, okay? They have hyperinflation, air trapping. These lungs are huge, okay? They have what we call a barrel-shaped chest. Now, when you look at my chest, all right, it's kind of like anterior and posterior, like kind of compressed. It's kind of like thinner that way, but longer, but thicker the other way. They have more of a circle. If you take a cross-section of their chest, it's more like a circle, as though a barrel's there, right? So that's why, because their lungs are so hyperinflated. And you'll see with a chest x-ray what it looks like. So what happens here, what causes this, is 90% of cases, it's because of smoking. The smoking actually destroys, in a way, and I'll show you what it looks like, but it actually will destroy the integrity of the membranes of the lungs, the alveoli. They kind of get over 10% where it has like this congenital disease called alpha-1 antitrypsin deficiency. 10% where it has like this congenital disease called alpha-1 antitrypsin deficiency. I'll show you what that looks like. I won't ask you about those, but I want you to understand what it looks like on the next slide. Even though 90% of the causes is because of smoking, only 10% of smokers end up with emphysema. Okay? Just to show you on that. So what kind of things can you see in these people? All right, well, like I said, they have that barrel-shaped chest, a big chest because the lungs are hyperinflated. They have a prolonged expiratory phase when they breathe out. It takes a long time. It's a long time to get that air out, okay? They use their accessory muscles to exhale. They'll use their abdominal muscles to get that air out. They use their intercostal muscles to try and get the air out, squeeze out that air, okay? They usually have wheezing. There's cyanosis that is also there, you know, because they can't get new air in there. So they end up turning blue on their fingers and their lips, okay? Central versus peripheral. Peripheral cyanosis is that they get it on their fingers first, away from the central area. That usually goes first. When you start seeing lips and tongue being blue, that's critical. That person it has to get oxygen and go to the hospital. All right, that's not a good sign. That's a late sign. Like I said, the chest X-ray tends to look very large too. It's overinflated. Okay, so this thing here. All right, this alpha-1 antitrypsin, what this comes in is this. Normally we have something called elastase. When it gets in, when the lungs get inflamed, elastase is going to go in and start breaking down some of the elastic fibers so that it doesn't turn into a restrictive disease. So you want to break that up when inflammation happens. So normally it would break it up. Well, this is what smoking does. Smoking is actually going to increase the amount of elastase to happen. So now you're going to really lose a lot of the elastic fibers. So much that you're going to not be able to, when it stretches, you're not going to be able to recoil it down. Does that make sense? All right? also, that's what's happening over here. But what's happening here is that this alpha-1 antitrypsin will normally stop that from happening when you have too much of it. So what smoking is going to do is going to decrease this, so it's not going to allow this to happen, and it's going to increase this. So because smoking does two factors, you end up getting emphysema. That's how it works. There's that other 10% where they're born with none of this alpha-1 antitrypsin. These are usually the severe cases. So they don't make this at all. Okay, not because of the smoking, just that it makes it at all. So I don't want to ask you too much about this. Just understand what smoking does. Okay? So what does it look like? All right, this is what our lungs look like over here. Here's a bronchiole over here, and here's your alveolus. That's what it looks normally. In a person who's had emphysema, this is overly inflated, the alveoli. It's overly stretched. Air can get in, but can't get out. Think of that baggy balloon. You also see it over here. Normally, air can come in and come out, no problem. There's the alveolus, there's the bronchiole. But in a person who's got emphysema, air can come in, it's going to overly stretch, and also we're going to see some of the bronchi over here is going to collapse on itself. And it's also going to contribute for air to go out. Exhale. You also see here, and this is the honeycomb I was trying to show you before. This is the honeycomb architecture that you should have in the lungs. When someone who's got emphysema, the honeycomb shape over here turns into gigantic areas that don't look honeycomb anymore. These are what your alveoli should look like, but when they start bulbing out like this, these are called bullae, all right, or one bulla or many bullae. And when they start ballooning out like that, it's difficult to get the air out of that area. Now, some of these can actually rupture. And when these bullae rupture, this air goes into the pleural cavity. And that can actually cause a pneumothorax, which we'll talk about. Okay? That's a bulla over here. This is normal architecture of the lungs. These big areas is emphysema. You should not see that with a naked eye like that. This is all normal lung tissue. These are okay. These are actually bronchi. All right, so they're going through into the lungs. So these are bronchi. But the normal architecture, when you look on there with a computer, this area here is has nice honeycomb kind of shape. But when they get overly stretched, you lose that honeycomb shape, and you'll see what it looks like over there. Okay? Under the microscope, this is what we normally should see. This little hole, or this little round circle over here is an alveolus. And there's a lot of alveoli around here. If you look at this, there's probably, and this is like 40x on the magnification, there's probably about like 50 or 60 alveoli in that picture. But when you take the same picture, a magnification at 40x on someone who's got emphysema, you probably can see maybe 5 or 6 alveoli, because it's taking this fishnet and overly stretching it. So this here is an alveolus, so you can see how thin the walls are over here, and this is a lot of air trapping that's going on in here. It's difficult to get that air out. Okay? This is the chest x-ray, what they look like. Here's the normal lungs. You see the spacing in between the ribs. The spacing in the ribs here are much bigger. You can see that. You can also see here, this is the lateral view. Normally you'll see that the chest is like this. Now the dark area is saying that that's where air is located. The whitish area is some kind of tissue that's there, soft tissue. Okay? So what's happening here is that we see some air over here, but in a person who's got emphysema, look at all that air that's in here. It's huge. The chest is more of a barrel-shaped chest. It's overinflated. Okay? Here's a person, I think he's dead here, but look at the chest. Look at how it's overinflated. It's big. Right? The chest is like a chest, we call it barrel-shaped chest. You also have these things called pink puffers. All right? These are patients who solely have emphysema. We're going to talk about chronic bronchitis in a moment, but people who have just emphysema, they have these pursed lips that I was talking about. Okay? And what it is that, like I said, it creates that positive pressure so that things don't collapse inside. So they breathe those pursed lips. But because they're doing that, their face turns beet red. I mean, you try and do that through a small hole, you'll turn red too. So because of that, they're called pink puffers because their face and the skin become reddened because of the way that they're doing it. So sometimes they're referred to as pink puffers. Okay? Patients typically look as though they're not emancipated. I spelled that wrong. What's the word I'm looking for? Emaciated. Yeah. They look cachexic. So in other words, you can see the ribs on this person. Okay? They're not usually obese. They're usually someone who lost a lot of weight. Okay? And that's what happens with that. And like I said, you see that barrel-shaped chest that they have. So we call those pink puffers. Okay? Long-term prognosis is very poor for these patients. Death is usually because the overload of acidosis that's happening inside their blood. All right, so they usually die from that, just too much carbon dioxide, or they die from right heart failure, pneumonia, or pneumothorax. As I mentioned before, you could rupture one of those fragile bullae, and then that air is going to go into the pleural cavity and cause problems. Okay? Questions on that? It was a big chunk, very important, but something where we need to continue talking about this is something called chronic bronchitis. Chronic bronchitis is some kind of irritant that's coming into the lungs that's chronic. Smoking is a good example. Smoking all the time is going to be a chronic irritation of the bronchioles. So now we're not talking about the alveoli, we're talking about the bronchioles now. Okay? Well, it could be the bronchioles with emphysema too. But it's chronic. It could be pollution in the air. All right? Some kind of chronic irritation going on here. All right? Coughing. We usually have coughing that lasts for about 3 months. 3 consecutive months within 2 years. That's how we define as chronic bronchitis. Okay? Most cases, it's because of smoking. And pollution could be another thing too. All right? You increase sputum production, as we explained, because it's all going to be irritated, it's going to be inflamed, and this can lead to emphysema or right heart failure. Okay? So we also have people called blue bloaters, as opposed to pink puffers. I know it sounds cruel and all, but that's what we call them, okay? In this case, a blue bloater is a patient that solely has chronic bronchitis. They don't look the same. They have more of an obese pattern, so they don't look like they lost weight. They look very cyanotic because they can't get the oxygen into their lungs because there's so much of the air trapping in there because of the mucus, all right? And their face tends to be like cyanotic. Their face and skin becomes more bluish in color. So that's why we call them blue bloaters, okay? And like I said, the typical person is an overweight smoker, okay? It kind of looks like that. All right? Then we have You put them all together now you have COPD. COPD is a combination of emphysema and chronic bronchitis, all because of smoking, right? You have the chronic bronchitis because there's smoking going on there. You have the emphysema because it's destroying the membranes of the alveoli. So we see a very common thing is COPD, all right? Now, some places, I know in England, they call it COAD, and I like that better than COPD because it actually tells you exactly what it is. You're obstructing the airway as opposed to obstruction in the pulmonary. You don't know what you're obstructing, but get an idea with that. So some places might call it COAD. But many smokers have this, and keep in mind, this is the third killer in America. Like I told you before, make sure you know the 10 killers in America, because I guarantee they will be on my test, they will be on all the NCLEX and all your other tests in the future, because these are the patients coming into the hospitals, coming into the offices. All right? They want to make sure that you feel comfortable with the 10 killers, because these are the most common things coming in. They will ask you questions on it, I guarantee it. Okay? All right, cystic fibrosis, I'm really not going to spend time on this because we already dealt with this before. But remember, what happens here is that you get a lot more mucus that's produced in the lumen of the alveoli, and it's due because the chloride pumps are not working, right? It produces more of a mucus that goes out there than an aqueous or watery solution. And this mucus that goes out there is a great medium for bacteria to grow in. So you're going to see someone with cystic fibrosis that has a lot of respiratory infections, and that's unfortunately the reason why they usually die. Okay? One thing that people with cystic fibrosis has is something called bronchiectasis. Bronchiectasis is, well, bronchi means bronchus, ectasis means dilation. So they have their bronchi overly dilated. And they're getting overly dilated because of all this mucus production. I mean, if I take this balloon and I stuff it with a lot of, let's say, foam, and I push more and more and more and more in there, and let it sit there for about 10 days, and I take all the foam out, isn't that balloon going to take the shape of this dilated balloon now? Because you left it like that? That's what's happening with the mucus. The mucus is actually making this permanently dilate, and that can cause problems, okay? So you have this permanent enlargement, and you lose the elasticity. Again, these are all obstructive diseases we're talking about, right? So you increase the respiratory infections because that mucus is a wonderful medium to grow in, bacteria to grow in. So they have this purulent mucus. Purulent means pus because there's so much respiratory infections there. And this is commonly seen in cystic fibrosis and in other diseases also. Okay? And this is a picture of bronchiectasis. You can see this blue-whitish color of mucus here that kind of shows you that it's purulent. It's